have around 70 plus attendees. Right. Yes. Good evening, afternoon, ladies and gentlemen, all attendees, fellow colleagues across Asia. Thank you for attending today's event, 18th FARO webinar, organized by MOS, IROS, Aurora. I am CHOONG, clinical oncologist from Pinang General Hospital, Malaysia. It's my pleasure to be your moderator for the day. As we are about to begin, I have few housekeeping announcements to make. Firstly, if you wish to ask any questions, please click on the raise hand icon at the bottom of screen or type your questions on chat box during Q&A sessions. And if you've experienced any issues in having today's webinar, please contact us. Our support team will help you in troubleshoot any issues. For today's agenda, we will start with lecture on topic of hyperthermia as an adjunctive treatment for cancer therapy by Professor Fuang for 30 minutes, then followed by 30 minutes of panelist discussions and Q&A sessions. To our distinguished speaker, Prof. Fuang, panelists, and to our participants, welcome to 18th FARO webinar. We appreciate you taking time off your busy schedule to join us today. We hope you will find this webinar to be fruitful and engaging. Now, please allow me to introduce our guest speaker for this evening, Professor Fuang from Malaysia, is current head of Department of Clinical Oncology at Universiti Malaya Medical Center, as well as head of program for Master of Clinical Oncology. He is heavily involved in national and international research work, and his research interests involve breast, gastrointestinal, and gynecological cancers. Next, please allow me to introduce our panelists for today. Dr. Nagraj HUILGOL from India. He is founder of Department of Radiation Oncology at Nanavati Super Specialty Hospital and also editor of renowned journals. His main interests are hyperthermic oncology, neuro, and gynae oncology. Dr. Shaowen from China is chief physician, graduate tutor of Beijing University Cancer Hospital, secretary of Department of Radiation Oncology, Peking University. He is key academician in a few hyperthermic committees. Dr. Sunanta TUNGFUNG from Thailand, graduated from Sri Nakarin University and the Thai Board of Radiation Oncologists from Sri Raj Hospital, Thailand, and currently work as radiation oncologist in Chulabhorn Hospital. To kick off today's program, I am pleased to invite our esteemed FARO treasurer, Dr. Junlin from China, to deliver welcome remarks. Dr. Junlin currently works as radiation oncologist in National Cancer Hospital, Chinese Academy of Medical Science, Peking Union Medical College, Beijing, China. Please, Dr. Yi.
Thanks, Siri Chuang. Dear experts and all my old and new friends and all attendees, good evening and good morning for everyone. Thanks for your taking time to join tonight's webinar. I'm very glad to join tonight's FARO webinar and give my warmly greeting to all participants. FARO is a big family, consists of 14 radiation oncology societies from Asia, which cover almost half of the population in the world. FARO always devotes himself to promote cooperation, share experience, and dissemination knowledge among members since its foundation. During the COVID-19 pandemic, FARO conducted a series of webinars to promote academic activities. Today is the 18th FARO webinars focused on hyperthermia. As we all know, Hyperthermia is a unique method to cure cancers, and it has synergistic efforts when combined with radiotherapy, chemotherapy, especially for head and neck metastatic lymph nodes, and peritoneal perfusion for implanted metastasis lesions. Nowadays, hyperthermia is used much less in China as before, but I'm not sure how about the situation in other countries within Asia. Also, so I think from today's webinar, we can know more about hyperthermia in the treatment of cancer combined with other modalities. I hope tonight's webinar bring us knowledge and experience and about how to use hyperthermia in the management of the cancers. Many thanks to our colleagues from Malaysia. Thanks for your hard working, preparing so great a webinar for us. Thanks to our colleagues from Indonesia for your IT support. Thanks all attendees from joining tonight's meeting. Wish this meeting make a great success. Thank you.
Thank you, Dr. Yi. Now I shall invite our President of Malaysian Oncology Society, Dr. Muthukkumaran THIAGARAJAN, to deliver his welcoming speech. Dr. Muthu is currently working as clinical oncologist in Hospital Kuala Lumpur. Dr. Muthu, please.
Thank you very much, Dr. Chong. Right. Very good morning, good afternoon, and good evening, everyone. So thank you very much for attending the webinar today. Primarily, I would like to thank the FARO Education and Training Committee, led by Dr. Mayang Permata, for actively organizing the monthly webinars. And we are very proud to actually host the current webinar from Malaysia. So on behalf of Malaysian Oncological Society, this is truly a very happy moment for us. I would like to mention a special word of thank you to Dr. Marniza Saad and Dr. CHOONG Hsia, who has been very, very instrumental in coming up with the program that we have in hand today. And also Dr. Junlin for being here as a representative from the FARO Council. So hyperthermia has always been a very daunting subject. We have always read it through our preclinical days. However, we hardly have any real-life applications where majority of us are concerned. Very few of us are actually privileged to actually work in areas related to hyperthermia, such as the speaker as well as the panelists that we have had in hand today. I'm sure we've got something very exciting ahead of us to be learned, and hopefully it is something that we can actually use and apply in our daily work practice in the times to come. So with that, thank you very much, and back to you, Dr. Chong.
Thank you, Dr. Muthu. Now shall we take our group photo?
Okay, good afternoon. I'm Maisa from IROS. I will be assisting you in taking pictures, taking our group pictures. Kindly please turn on your camera. Okay, I will be taking your photos in the count of 3. Please hold still for a moment so we can get clear picture. Okay, 1, 2, 3, smile. Okay, maybe once more. Okay, 1, 2, 3, smile. Okay, the picture has been taken. Thank you very much. Back to you, Dr. Xiong.
Thank you. Now, it's now my pleasure to invite Professor Ho Kuo Fang to present to us on hyperthermic as an adjunctive treatment for cancer therapy. Professor, the floor is yours.
Thank you, Dr. Chong. First of all, a disclaimer. I'm not an expert in hyperthermia. I was coerced by Professor Maniza to present the talk just because I did a small study on hyperthermia. So if I make mistake, please let me know. We're just here to learn. Second thing is I'm not sure how much time we have because I prepared a few slides. So if time is up, then I'll just stop talking and then we can go to the panel discussion. So the title is set by my previous medical officer, Dr. Izzati 1. So I borrowed many of the slides from her. So thank her for that. Hyperthermia as an adjunctive treatment for cancer therapy. Hyperthermia is the application of heat to in medical use to a patient's body for the purpose of cancer treatment. Modest elevation of temperature to a range of 39 to 45 degrees. The raising of temperature can be local, regional, or systemic heating, treating the whole body depending on the aim of the treatment. Energy is deposited into the tumor mass obtained from the external device. So I borrowed our great mentor, Professor Jans Overgaard, who said this in the Astro conference in Madrid last year. Hyperthermia represents the most powerful biological modification of radiotherapy ever seen, but its full clinical potential has not been explored, mainly because of technical problems, and also there wasn't much commercial incentive. Consequently, we may be missing a major therapeutic achievement. So what are the rationale for using hyperthermia? The three main ones would be radiosensitizer, chemosensitizer, or immunomodulator. So hyperthermia, we talk about radiosensitizer. Hyperthermia has three main functions for radiotherapy. One, it improves the tumor perfusion and oxygenation. Secondly, inhibition of DNA repair mechanism, increased formation of toxic DNA double-stranded breaks. Thirdly, damage to radioresistant S-phase cells. And this effect is present at mild hyperthermia around 40 to 42 degrees. Let's talk about oxygenation. The reoxygenation mechanism displays a different dose-effect relationship. So the blood vessels start to open up at 40 degrees, and it will shut down at temperature higher than 44 degrees. So there is a window where reoxygenation is at the maximum. And hence radiosensitization by this mechanism is thus optimal during a mild temperature hyperthermic regime. The reoxygenation effect is reported to last for 24 to 48 hours, i.e. it has a larger window of effect, even after perfusion levels have returned to normal after the end of hyperthermia session. So this is the effect that lasts a long time, not a long time, but a day or two. Secondly is the effect on DNA repair. DNA, RNA synthesis, DNA repair mechanism, and cell respiration are inhibited by hyperthermia. Tumor cell membranes in the presence of heat becomes more permeable and to fluid. This may partially explain the increased uptake of drugs. Heat increases the influx of reactive oxygen radicals, mediating in part cytotoxicity. And DNA polymerase beta, a key enzyme in multi-step repair system, is strongly inhibited. So heat has a direct effect on DNA repair. In diagram, so viable cells, with radiotherapy, you get DNA damage, DNA cell kills, and hyperthermia inhibits the DNA repair. In the tumor microenvironment, hyperthermia improves perfusion and reoxygenation. We didn't talk about immune response. Disturbance of the tumor microenvironment. Therefore, you get more DNA damage, more cell cycle arrest, less DNA repair, and more apoptosis with increasing temperature. When we learn radiobiology, we learn the term thermal enhancement ratio. So in vitro experiment shows a strong dose-effect relationship for hyperthermia with thermal dose, doubling for every 0.5 degree rise in temperature between 37 to 42.5 degrees Celsius. And clinical results confirm the existence of significant dose-effect relationship. So thermal enhancement ratio is defined as the ratio of the RT dose for RT alone divided by RT dose for RT plus hyperthermia, reaching isosurvival for cell survival curves in the in vitro study. So both in vitro and in vivo models confirm the strong dependence of thermal enhancement ratio on both temperature level and duration of the treatment. So both the temperature level and duration of hyperthermia. Third mechanism is a direct cell killing. Hypoxic tumor tissues are more sensitive to hyperthermia than normally oxygenated tumors. direct cell killing is responsible for part of the apparent radiosensitization of hypoxic tumor tissues. There's a strong dose-effect relationship exists both for direct cytotoxicity of hyperthermia and for radiosensitization due to inhibition of DNA repair. So direct cell heat killing, which happens at higher temperature, is more apparent on hypoxic cells. When you talk about the alpha beta, so the alpha killing, so the straight curves, and the beta, which is it's a square with sublethal killing, so direct killing, direct path from alive to dead, alpha killing, and then the beta with accumulation of sublethal damage and become fatal for the cells. Hyperthermia will sensitize the cells, therefore it lowers sensitize the cells, therefore affect both direct cell killing and sublethal damage. So the effect of the hyperthermia on the survival curve would be that the curve is first of all shifted down as a consequence of the hyperthermia itself, i.e. the direct cell killing. There's a steeper initial slope because of enhancement, reduction of the DNA repair, therefore enhancement of the direct the one hit, one death killing effect, and the shoulder also reduced. So that means you get a steeper curve, survival curve, which starts at a lower point when you have hyperthermia together with radiation, the effect on the cell survival curve. So just to recap, so when we see a cell survival curve, we have a shoulder, and at higher dose, there's more cell killing. And this shoulder, due to sublethal damage, becomes more lethal when we have hyperthermia together with the radiation. This is the effect of thermal enhancement. So when we work out the thermal enhancement ratio, so the dose required to kill certain fraction of the cells, and with a different survival curve, you need a lower dose to kill a certain fraction of the cells. So the higher dose divided by lower dose is the thermal enhancement ratio. So that's what we see in the radiobiological equations. The thermal enhancement ratio effect on it is actually dependent on the sequence and time interval between the radiotherapy and the hyperthermia. So comparing the tumor and the normal and the skin, which is normal tissue, so the effect is most is the TER is highest at 2.5 when hyperthermia is given at 42.5 for 60 minutes degree for 60 minutes during the radiation, but also immediately before and after. So that's when you get the most effect. You get the same effect in the normal tissue as well. The DNA inhibition it depends on the cell healing, cell repair. That one is 4 hours before and after. And then there is an additive effect from direct cell killing, which is with the TER of 1.5, which is not seen in the normal tissue. So that means that it is time dependent. The effect of hyperthermia on the TER is time dependent. So we go back to the mechanism of the effect of hyperthermia. Inhibition of DNA damage repair is only effective when the cell is in the process of repairing DNA damage caused by radiotherapy, i.e. up to a few hours after radiotherapy. Therefore, a time interval shorter than 4 hours result in significantly higher TER, reaching the highest TER when RT and H hyperthermia are given simultaneously. Repair of DNA damage takes up to a few hours, so the increase in TER for time interval less than 4 hours is likely to represent radiosensitization by blocking DNA repair in both tumor and normal tissue. Secondly is the reoxygenation effect has different impact on optimal sequence and interval. This mechanism is effective when hyperthermia is given before radiotherapy. Compared to the other two mechanisms, the time interval is not so critical for reoxygenation because the effect lasts for 24 to 48 hours, even after perfusion level have returned to normal after end of hyperthermia session. So due to the long time over which the reoxygenation mechanism remains effective, hyperthermia session, one session will boost the RT session of the same day, but also the RT session in the next 1 or 2 days. Then direct cell killing, the TER of 1.5 for the tumor when hyperthermia is given 24 hours after radiotherapy. So this is unlikely to be due to DNA damage effect or reoxygenation. So it is attributed to probably due to the direct cell killing any contribution to TER at this long time interval must therefore represent a mechanism independent of RT, such as killing of the hypoxic tumor cells. So that is the understanding of the observation we see. The extent to which direct cell killing contributes to TER will depend on both the temperature level and the presence and size of the hypoxic fraction, which will vary per tumor type. So a graphic representation of the different mechanism at different temperature level. So increased blood flow and reoxygenation becomes active at relatively low temperature of 39 degrees, peak at 41 to 42 degrees. So that is the reoxygenation effect, and reverses at 44 degrees. So there's you can overheat something. Effective inhibition of DNA damage repair inhibition requires higher temperature exceeding 41 degrees. So after 41 degrees, DNA repair or inhibition of DNA repair takes effect. And it's not the same as if you do it as simultaneously or sequentially. So temperature requirement is different. For heat exposure at temperature above 43 degrees, cell death occur at constant rate. So cell death occur due to direct cell killing, more so easier for hypoxic cells than aerobic cells, more resistant to hyperthermia. So this is the different effect, taking different mechanism occurring at different temperature level. There is such a thing called cumulative equivalent minutes at 43 degrees Celsius. This is to express the therapeutic effect depends on the temperature and duration of the heating. So for short exposure time at temperatures below 43 degrees, the cell survival curve will show a shoulder, which indicates accumulation of sublethal thermal damage. For increased exposure time, these shoulders will turn into constant rate of cell death, followed by several hours, followed after several hours by lower rate of cell death due to something called thermal tolerance, which is an observation that people notice. So the duration, so reoxygenation lasts for about TER, so it lasts for 24 hours to 48 hours, and then the DNA repair 4 hours, and then the direct cell killing is a constant process. So thermal tolerance, temporal resistance to subsequent hyperthermia treatment lasting for about 2 days after hyperthermia is another phenomenon adding to the complexity of timing of hyperthermia and relevance for thermal radiotherapy planning. The onset, duration, and degree of thermal tolerance depends, among others, on temperature and heating time. The normal tissue, because if you heat up, if normal tissue is equally sensitive, then there's no good. Hyperthermia blocks DNA repair and causes radiosensitization in normal tissue, depending on the sequence and time interval, but sensitization is less than in tumor tissues. So for the DNA repair, is less sensitization compared to tumor tissue. The other mechanism, hypoxia, is absent in normal tissue, so direct cell killing and reoxygenation generally do not play a role. So there is some differentiation in terms of response to hyperthermia between normal tissue and the tumor. Normal tissue damage by direct cell killing can occur when temperature exceeds 44 degrees. Therefore, normal tissue hotspot when we do hyperthermia should be avoided during clinical hyperthermia. So the chemosensitization, there are different drugs seems to have different effect with hyperthermia. The one that's most effective with synergistic effect is platinum and mitomycin C, which are the drugs we use in HIPEC, in the HIPEC procedures. But other drugs like doxorubicin, cyclopentadine has additive effect. Hyperthermia, how does it affect the chemotherapy? Leads to increased apoptosis through several biological processes, increased tumor membrane permeability, we talk about increased production of oxygen-free radicals, inhibition of DNA repair, and alteration of cellular cytoskeleton. There is change of expression of the apoptosis gene, such as p53, BCL2, and FAX, and it also activates a different apoptotic pathway, which involve caspases 3 and 7. So hyperthermia in combination with drugs promoting apoptosis produces synergistic effect. So this is just another representation of the drugs that works best with hyperthermia, things like mitomycin C or platinum agents so which works even better in hypoxic cells or acidic cells. And also bleomycin, which we don't tend to use so much with hyperthermia. Those are the drugs that has some synergistic effect. Lastly, the immunomodulatory effect of hyperthermia is that hyperthermia seems to enhance the antigenic presentation to affected cells and the production of heat shock protein. And many aspects of the innate and adaptive immunity, such as natural killer or heat shock proteins, are modulated by hyperthermia. And thus, in particular, heat shock protein 70 has been found to act as a recognition structure for natural killer cells, increasing their activity. So increased vascularity, increased heat shock protein, especially heat shock protein 70 production, increased release of exosomes, activation of NK cells, also increased activation of dendritic cells, priming of CD8 T cells, causing tumor lysis. So it has effect on the immunopresentation and activation of NK cells and dendritic cells. Types of hyperthermia. So when we talk about hyperthermia, actually there is a broad term. They are the local heating, which we won't go through today. That's like RFA, microwave ablation, or the hyperthermia in the bladder, or HIPEC. HIPEC is this one. Superficial hyperthermia, like using infrared electroporation, or nanoparticles. Nanoparticles are conductive way of increasing heat, also high intensity focused ultrasound, which we'll go through a little bit later. The local regional hyperthermia is with the capacitive heating with 2 electrodes heating up the body, or with radioactive local regional, which focus more of the radiation to a certain part, and isolated perfusion, which I have never done, that's in the textbook, and HIPEC, which we do offer. And in Germany, very popular full body heating, which we don't have the facility, and actually it's a little bit requires a bit more care because it's a bit more slightly more dangerous. So full body heats up to about 42 degrees, local regional about 45, and local ablation up to 100 degrees. So if you heat up the body more, the time to create fibrosis or necrosis, if the temperature is higher, it takes shorter time in log scale to cause fibrosis and necrosis. For example, 40 degrees, it will take 10 to the power of 4 to cause fibrosis. So that means actually you can see it drop quite fast with rising in temperature, the effect on the tissues. Quickly, hyperthermia versus thermal ablation. So if you increase the temperature to very high, then it's thermal ablation. So it's a local ablative technique. So thermal ablation aims at generation of temperatures above 50 degrees for a few minutes in a single session to destroy tumor cells by heat alone. Okay, so that's thermal ablation. Hyperthermia is only heating it mildly up to a maximum of 45 degrees. Hyperthermia can be used routinely for different tumors like cervical cancer, patient unfit for chemotherapy, recurrent breast cancer, and so on. Thermal ablation is, we know about it, so I won't go through, because I want to talk a little bit about the methods of heating, which is something that is confusing for most of us, which is also something that we try to learn a little bit. Hyperthermia and thermal ablation can be produced using a variety of techniques. Clinically used heating techniques are electromagnetic heating, ultrasound, hyperthermic perfusion, and conductive heating. Okay, so these are the 4 different ways: electromagnetic heating, ultrasound, perfusion, and conductive heating. So the 4 ways of heating up the body. So I don't know how much time I have. If I can use another 10 minutes to go through these different techniques, then Dr. Choong can stop me anytime. Okay,
actually,
so,
you have until 6:50, so you
6:50?
still have around 6:50.
All right, we have another 15 minutes. So that's because this one is very physics, it's a bit more difficult to grasp the idea. So electromagnetic heating, you put 2 electrodes on top of the one each side of the body. So you alternate the current at a certain frequency. So the water molecules in the body has a dipole. So it align itself with the positive and negative direction. Because the electric frequency moves fast. Therefore, these water molecules get turned one way or another accordingly, rapidly, creating friction and causing heating by this agitation. Also, the ions in the body will conduct the electricity, and that causes something also dielectric heating, also Joule's heating. So these are the technique, the radio frequency heating technique used for capacitive, radio frequency, microwave, this radiative, infrared, and laser heating. So these are the electromagnetic heating technique. So just go through again. Electromagnetic heating techniques apply a high frequency alternating sinusoidal electromagnetic field generated using one or more antennas. The electromagnetic field causes dielectric heating by molecular dipole rotation, which are the molecules that has two poles, positive and negative poles, and polarization and vibration in the megahertz range, and also ionic conduction in the kilohertz range by the ions. So the polar molecules, they have electric dipole moment, and therefore these molecules align continuously with the alternating field. Electric forces cause rotating molecules to push, pull, collide with other molecules, thereby distributing the energy to adjacent molecules and atoms, causing dielectric heating. Okay, so by turning it to and fro, many times it creates this collision and creates heat. So it can be divided according to the different frequency, wavelength, and penetration depth. So these are listed here in ascending order of frequency. Okay, frequency goes up with the subsequent ones, and descending order of penetration depth. Frequency goes up, penetration depth goes down. So radio frequency, the commonest one used in commercial machine, either capacitive arrangement or radiative arrangement. And then there's a microwave heating, and then infrared heating, and the laser heating, which is not used for oncology. So these are the different frequency of electromagnetic heating. So we talk about capacitive heating. So you put the metal electrodes, which that are coupled with high power radio frequency generator, operating frequency typically 8 megahertz up to 27 megahertz. So electrodes are applied in pairs with target region in between the electrodes. You can put some water bottles between the electrodes and the body to transfer the current, also to cool off the skin. So you can put water bottles, or you don't have to put water bottles. An electric field is applied between the electrodes, and power is deposited in the tissue as a result of alternating voltage field we talked about just now, the dielectric heating. So the energy absorption in tissue by dielectric heating depends on electrical conductivity and permittivity, which varies between different tissue. Therefore, excessive temperatures can occur at tissue interfaces, and due to the orientation of main electric field component, which is perpendicular to the fat layers, so fat will absorb a lot of heat, therefore can get a bit of fat necrosis. Okay, so fat would be the first one because at the surface. Therefore, capacitive heating becomes less effective with increasing thickness of the fat layer. So a lot of fat will absorb a lot of heat, and heating of deep-seated tumors can be challenging. So that is the limitation of this technique. So two electrodes, so like radio frequency, so you polarize the molecules, and depth to 3 cm response rate is 68%, deeper tumor 54%, more than 6 cm, the response rate goes down. So the kind of heating that you see is something like that. Very much like what we see with 6 MV photons. So the problem of classical capacitive hyperthermia for tumor which is deep is overheating of the fat layer and no electronic focus steering, which is to come to discuss this in a minute. So how do we improve this? This is very much like the shape we see. One is you can increase number of electrodes. So you have 2 pairs of electrodes. So this is a phantom study. So 1 pair is like this. So 2 pairs maybe can get better dose concentration in the middle. This somebody who experimented on this. The other one is maybe you can reduce the frequency. So with the reducing frequency, the penetration goes deeper. So this is the machine that we use with the remission 1 degree C. This has the lowest frequency in the market of 0.46 megahertz. So when the energy goes below, the frequency goes below 1 megahertz, the Joule's heating by the ionic conduction, that Joule's heating also becomes a heating mechanism. So there is a productive heating and also dielectric heating with the very low frequency RF field. So if we just, for completeness sake, this is the other one, the radiative radio frequency. Radiative radio frequency using the operating frequency about 60 to 150 megahertz. This radiative radio frequency wave is used for deep-seated tumor. How does it work? Because apparently this frequency range, in this frequency range, the wavelength is 25 to 60 centimeter in the muscle tissue and get a large penetration depth of the electromagnetic energy. And what they do is that they, sorry, I'll come to that in a minute. And microwave is another radiative RF wave at higher energy still, 400 to 2000 megahertz. It can also may use water boilers and also can cause inhomogeneous energy absorption in different tissues to create hotspots. So these two forms of radiative frequency, one is our radio frequency wave, there's a microwave. The heating device, it can be used, you can use single electrode or antenna or a few electrodes. So because it's at the far field of the RF field, so it becomes a radiation, non-ionizing radiation. So you can have a few electrodes and form a phase array, a few arrangement of the electrodes. And then apparently with physics, you can make these arrays to the waves can be arranged so that they form a constructive interference. So the two waves interfere with each other and form a bigger waves between the electromagnetic waves. So this is called power steering and focusing of the electromagnetic energy into the tumor. So by using this clever physics interference technique, so if you have two, let's say two sets of electrodes, you can arrange it to form constructive interference of the waves in the middle of where you want to heat up the body. So that is a clever way, maybe like us doing the conformal radiotherapy. So that is something which is more difficult to achieve with the capacitive technique because you cannot do this electric steering with the capacitive technique. So capacitive heating, so usually you get a hotspot on either end, so like this. So with radiative heating, so if you use that kind of steering technique, you can probably steer it one way or another, and of course energy is higher. So with I feel like us doing radiation. So that's the advantage of the radioactive system. Just for completeness sake, the infrared is a very high frequency of 300 gigahertz, strongly absorbed by water. But there's an issue when you have very high frequency is very superficial heating. So the penetration depth is typically less than 1 centimeter, suitable for superficial heating. For completeness sake, we go through the other few heating technique. So ultrasound heating is by particle vibration and pressure and kind of acoustic wave. So using acoustic energy at frequency 0.5 to 10 megahertz to heat tissue and induce either hyperthermia or thermal ablation. So in contrast to diagnostic ultrasound, the wave fields are weakly focused. Ultrasound transducers used for thermotherapy are often designed to focus pressure waves to converge on a specific zone. So the friction basically, frictional loss due to molecular collisions resulting from the applied ultrasound pressure wave, causing heating at the specific area. The hyperthermic perfusion basically is just heated blood or heated fluid supply, heat up the tissue, okay, and then recycle it. So that's something that we use for hyperthermic intraperitoneal chemotherapy, as for peritoneum, or for thorax called HITOC, which is similar mechanism, and you can use it for the bladder. It's called HIVEC. It's a branded another way to heat up the fluids that you instill into the bladder for hyperthermic chemo into the bladder. Last but not least is a conductive heating. Basically, it's a heat source heat up the body. Okay, so it's like a water bottle that patient used to heat the surface, which is what the Greek and Egyptian used for surface malignancy. But the difficulty is you want to treat a deep tumor, there's some problem with it. Until this person called Dr. Gilchrist, who designed these magnetic nanoparticles that can be developed, can be put into the body. And what it does is that when exposed to an external magnetic field, the magnetic materials will respond by aligning the atomic moments with the field, thus producing a magnetization that persists for a characteristic duration after the external magnetic field is removed. And the heat is generated by something called magnetic hysteresis, which is a loss mechanism for which the amount of energy released depends on the frequency and amplitude of the aligned magnetic field, as well as the intrinsic magnetic properties of the nanoparticles. So if you can get these nanoparticles inside your tumor, you use magnet to actually align it, and then the energy can be released afterward as by this mechanism of heat, magnetic hysteresis, and that is actually useful to target your heat to a certain place. So nanoparticles can be administered as function of small heat absorbers, so they absorb the heat and selectively heat up by outside electromagnetic field, which acts exclusively only on these nanoparticles. The overheated nanoparticles soon give up their heat energy to their neighboring neighborhood and heat up the complete region in their vicinity. The difficulty of this is the delivery of the nanoparticles, because you have to concentrate on the tumor cells exclusively on the membranes to damage them. So it requires high precision of delivering nanoparticles to the surface of the tumor cells. For example, you can probably label it with an antibody or something and load the nanoparticles into the tumor. And then you heat it up with antibody nanoparticles conjugate. That may be a way to deliver the nanoparticles. So finally, it's just the radiotherapy and hyperthermic combination. What has people done? So DNA repair mechanism, inhibition, DNA direct cell kill, DNA repair, direct cell kill, and reoxygenation. So you have to plan the hyperthermia and you plan the radiotherapy. So it's called TRTP, thermal radiotherapy treatment planning. For example, this example by Dr. Krisi, one of the leader in this field from Amsterdam. So that's the radiotherapy planning, and when they heat it up, they can incorporate the heating and the coverage of the tumor is better after they have the heat to compensate for the cold area at the back of the tumor. So this one is for Professor Maniza to think about, which I deliberately choose this example. Okay, so the idea is that radiotherapy alone with the hyperthermia, if you can focus it to the tumor, it's even better. Then you can add a few more grades. If you like, we do it with chemo or oxygen or this kind of things. You can dose escalate by about even 8 to 13 grades by doing this for cervical cancer, because the differential response, so the damage is so there's some therapeutic advantages. Hyperthermia may change the alpha beta tumor alpha beta. So from this paper, so this is something we need to take into account of. Significant change in the alpha beta ratio is of direct clinical interest for the selection of optimal fractionation schedules in radiation oncology, influencing the dose per fraction, dose fractionation, and dose rate in combined treatment. So they have thought about this in recurrent breast cancer or locally advanced head and neck cancer and locally advanced cervix cancer. When they plan the thermal radiotherapy, the alpha beta ratio is of interest. So the mean temperature hyperthermia is around that. That's the BED, which they get, and alpha beta is a little bit different, and then the response rate is a bit higher from Bata et al. From 3 years ago. So that is the difference in terms of planning with hyperthermia and with no hyperthermia. So the studies have been done, some randomized, some not. Basically have been done in breast cancer, cervical cancer, and also head and neck cancer, NPC, and rectal cancer, and esophageal cancer. So overall, if you look at it, it seems to report a higher complete response rate of about 1.5 times. And meta-analysis says hyperthermia with radiotherapy give a 2 times more effective treatment than radiotherapy alone from the breast cancer, this series of tumor types. So the Amsterdam regime is only give hyperthermia once a week and together with the radiation. So it's something that we can consider. I would run through our humble little 2 studies with 2 minutes to spare. One is to, we use the Edipolar remission 1 degree, 1C machine, which is the capacitive technique, which is the cheaper version. That's low energy, low frequency, so its penetration is better. But it takes 2 hours to heat up, take 1 hour to heat up to 41 degree, and then 1 hour to maintain. Therefore, it takes 2 hours. So it's a bit longer to heat up the patient. So we just tested them on a range of tumor types. I want to see whether the pelvic tumor, that's painful tumor, whether they respond to hyperthermia. Many of them are heavily pretreated patients. Many of them are performance status not so good. So we did find that the pain score goes down from about 6 to about 4 after about 8 weeks of treatment. But quality of life score has not changed. The other study is to combine it with a range of treatment. That is a mistake. I should have combined with a range of treatment, should combine with 1 treatment, but we learn from our mistakes. But the one we get is from the immune response. We look at the range of immune response. So next time if I do the study, I'll be more specific with 1 tumor type. So if so many tumor types, the range of performance status is hard to get a very good idea in terms of effect on the radiotherapy versus no radiotherapy, or chemo versus no chemo. So a range of chemotherapy lines. The T cells, we do not see much response on the T cells in the central memory T cells or effector memory T cells, but we do see that after 1 week of radiotherapy of hyperthermia, the what's this CD62, CD4 helper cells shift up. You can see the cells are randomly distributed, but many of them went up after 1 round of hyperthermia. This one before chemo is after chemo. This one after 4 weeks. So that's something we did find. Also, NK cells seems to have some kind of response. And cytotoxic NK cells at week 4, there was a bit of response moving upward trend. But the thing is, it's a bit complex because regulatory T cells expression also seems to go up. So don't know how that affect the immunomodulation. Yeah, but the other checkpoint inhibitors markers are not altered. Okay, so our finding is that significant improvement in terms of pain score, but no effect on the quality of life score, and some effect on the immune response of the patients. Finally, I want to end with 2 slides from the president of ESTRO. Biology, hyperthermia selectively eliminates tumor cells and enhances immune response. Thermal tolerance, we need to bear that in mind. Challenge to obtain homogeneous heating in the correct location. Optimizing hyperthermia treatment planning. Use of MRI to measure 3D temperatures. There are many small randomized trials and not many small trials, but not many randomized studies. So many technological developments that now enable robust and reliable application of hyperthermia. We need multi-center randomized control trials, and if positive, will be incorporated into the guideline. So thank you.
Thank you, Prof, for comprehensive and informative talk. I can see few questions from in the chat box, but I will leave it to the end. So next, I shall invite panelists to share opinion on Prof whole lecture and experience in hyperthermia. May I have Dr. Nagsha HUILGOL to share your opinion or experience in the thermotherapy?
Yes, well, it has been a very comprehensive talk on various modalities of treatment that's available, and I mean that Dr. Datta's meta-analysis is fairly comprehensive, to have a clinical insights. Now, we at Nanavati Hospital, I set it up in 2000 after Van der Zee's seminal paper, which was published in Lancet, I think. Or Nature, sorry, on cervical cancers. And that kind of revived the interest in hyperthermia. And we had machine, radio frequency machine, capacitive, as he had described already, 8 megahertz or 8.2 megahertz, and input could go up to 800 watts in our machine. But in the original thermatron, it can go up to 1,000, 1,200, and after impedance management and preheating, cooling, and also cooling during the treatment. We have treated nearly 3,000 patients, or predominantly we have had head and neck cancer patients, because it's one of our big problems and very easy to heat. All those graphs that he showed, and of course I see a lot of them from Hans Kriese, a dear friend, they all look very elegant in the laboratory. But we must understand that heating is not so easy, because most of us, the human beings or mammals, are not designed to retain heat. So heating anything up to 42, 43, 44 degrees Celsius is a very, very Herculean task. We don't very often get there. And but mercifully, as the earlier talk has expounded appropriately, mercifully we have a biphasic. We have two types of response to hypothermia. One at a lower temperature of 39 to 40, and one between 43 and 45 degrees Celsius. In a head and neck tumor, I published a randomized trial wherein it's published in JCRT, wherein we randomize the patients to radiotherapy alone and radiotherapy hypothermia. It is there in Dr. Datta's paper, mentioned there in the Dr. Datta's paper. Well, a very small study, because it became a little difficult to continue with that randomized trial, because chemoradiation became a very standard of care. Then we also started integrating chemoradiation along with hypothermia. And as you know, cisplatin, when you add cisplatin, it's good for hypoxia, so is hypothermia. So predominantly we use cisplatin. Paclitaxel was also used. We have also published some data with arsenic trioxide as a thermal sensitizer. It was a phase 1 study in head and neck cancer. We have treated patients of cervical cancer with hypothermia and for palliation in an intra-abdominal tumor. So our primary work, or most of our work, and we have treated some soft tissue sarcomas, but in most as a randomized trials or prospective analysis and so on and so forth, has been in head and neck cancer, then cervical cancers, very, very, very few pancreatic, and of course for the pain management in the bone. So nearly we must have treated on 3,000. We have combined with targeted therapies, arsenic trioxide as a sensitizer, a randomized trial to compare radiotherapy alone with radiotherapy and hypothermia, chemoradiation with hypothermia in head and neck cancer. What is very, very consistent, my personal experience here is, no matter which site you treat, and no matter how much, even if you can achieve the temperature 40, 41 degrees Celsius, you do have a favorable outcome. I mean, there could be various reasons as to why it works, right from reoxygenation to fixing the DNA double-strand breaks, or affecting the cell membrane, which is a different and distinct site than site for radiation damage, and it also affects the hypoxic core with a direct cell kill. So in my clinical practice, whenever we have used hypothermia in a randomized fashion or in a prospective in a clinical setting, there has been an additive effect, either in terms of survival, as was published in randomized trials, or definitely in initial response, progression-free survival or disease-free interval. It is a very, very useful adjunct or adjuvant or add-on to radiation alone or chemoradiation. There is a lot of literature, and I hope all of you really take it up in a big way and make it really big and happen in Malaysia. Thank you so much.
Thank you, Dr. Nagraj HUILGOL, for telling us and giving us so many randomized trial. So next, shall we move on to Dr. Hsia? Is there any comments from Dr. Hsia?
Hi, sorry. I am one of the students for Professor Hsia. He has outpatient clinic as we're speaking, so he did bring some
I think we can't hear you from China because the line is not good, but it's okay. I think, shall we move on to Dr. Sunanta first while waiting for Dr. Xiao's students' line connection?
Thank you. Okay. In my hospital is the hyperthermia use the thermoton RF8. We installed the thermoton RF8 in April 2014, about 8 years ago. For this machine, such as the Dr. Ho says, this machine has a two parallel opposite circular electrode to generate the heat at the radio frequency of 8 MHz. Is suitable for the superficial and deep tumor deep and superficial tumor. I think about this machine, the temperature is quite difficult to monitor. This machine used the thermocouple plastic to monitor the temperature. In my department, use the thermocouple to monitor the temperature to be placed on the skin over the region or insert into the cavity, such as the rectal and vaginal cavity. But during use the hyperthermia, patient often complain the skin pain. So in some case, we cannot increase power output to reach the suitable temperature, especially in case of patient had big subcutaneous tissue fat. In our practice, we increase power output to we increase the power output up to the patient tolerance. In my department, use the hyperthermia combined with radiation therapy or the chemotherapy or the chemoradiotherapy. We don't use the hyperthermia in a single modality. After we installed the hyperthermia RF8 about 3 years, we retrospective review in case in my department. We retrospective all of patients received the hyperthermia. Patient received the treatment hyperthermia combined the radiation or the chemotherapy, not used in the single modality. The most treatment common site in my department within the pelvic cavity and the abdomen, and almost of the patient, the disease is in the CA cervix about the 40%. We analyze the result. We divide patient into the two groups for about the curative aim patient and the palliative aim of the patient. We analyze in the curative aim patient the response for the patient in this group. All patient has the response, at least the partial response for the tumor. For the patient with the complete response has the tumor located in the pelvic cavity. And in the palliative aim, the result similar to the Dr. Ho. The radiation plus the hyperthermia can reduce can palliative the symptoms such as the pain, and the patient can reduce the analgesic drug and can quit all the analgesic drug in some case. For the toxicity, I saw in this paper, the most common side effects were grade 1 skin, such as the dermatitis, skin pain, or fat necrosis. In my retrospective review, only one patient developed severe grade 3 necrosis. Yes, this is the experience, the hyperthermia in my department.
Thank you, Dr. Sunanta, for sharing your experience in especially in cervical cancer. Let's now, shall we move back to Dr. Xiao? Dr. Xiao, any comments from Dr. Xiao? Dr. Xiao, we cannot hear you. We can't hear you, Dr. Xiao. Would you like to share your video and unmute yourself?
How about now? Can you hear me now? It's a little
Yes,
better.
we can hear. Yeah. We can hear you now.
Okay, great. Yeah, sorry. I'm actually Professor Xiao's student. He is doing his clinical time, and he wants me to bring his message to the audience, if that's okay.
Sure. May I
Okay.
know you are a doctor? How do I
I'm just,
address you?
my name is Lei Wang. I am one of his students.
Okay,
So
yes,
he is
thanks.
doing.
Yeah,
Okay.
Dr. Lei Huan. Yeah, you shall. Represent Dr. Xiao in giving your opinion.
Okay, yeah, so he prepared a little message to bring to the audience today. He is first wants to introduce himself. He is saying he is a member of the Council of Asian Hyperthermia Society. He is also a member of the Council of CISCO, which is the Chinese Society of Clinical Oncology. He's a vice chairman and chairman designate of Hyperthermia Special Committee of CISCO. He's also the deputy head of the thermal therapy group and radiotherapy branch, Chinese Medical Association, and the chairman of Hyperthermia Committee of China-Japan Medical Science and Technology Exchange Association. He wants to thank everybody to invite him today. Because it is his first time to attend such meetings, he wants to let everybody know he knows not very much about it, but he does want to introduce the general situation of hypothermia in China. He said at present, nearly 5,000 hospitals in China carry out such therapy. There are more than 10 manufacturers producing hypothermia equipments, and more than 100,000 patients are treated every year. Hot therapy sources for hypothermia include microwave, radio frequency, infrared ray, laser, and magnetic particles. It can be divided into superficial hypothermia, deep hypothermia, whole body hypothermia, and intracavity hypothermia, etc. In addition to the whole body hypothermia, hypothermia is often used as a means of comprehensive treatment. It plays an important role in tumor treatment, which can be combined with radiation, chemotherapy, targeted therapy, immunotherapy, gene therapy, and traditional Chinese medicine and other therapies. Moreover, in a palliative treatment of tumors, such as relieving the pain, hyperthermia also has a certain effect. He wants to let everybody know the 2024 International Hyperthermia Conference and the 8th Asian Thermal Therapy Conference will be held in Beijing, China, and he'd like to welcome all the friends and colleagues to join us. Thank you very much.
Thank you. Thank you. Comments from Dr. Xiao and your experience. Right. Next, let's move on to the Q&A session. If you have any questions from the floor, you can unmute yourself or raise your hand or type the questions in the chat box. So now I think we have two questions. The question number one, I think, is towards a Prof. Ho. The question is from Nurul Sufia. Is on, are there any hyperthermia treatment already practiced in Malaysia?
Certainly not as common as in China. As far as I know, I think we have a handful of units in Malaysia, probably no more than 5. I think we should promote hyperthermia in Malaysia more. Yeah.
Okay. The question number 2 is, since the thermal therapy increased perfusion and allowed drugs to accumulate in tumor cells, does it also increases the potency of metastatic niche? Because the heat therapy should given before the RT given. I think shall invite Professor Ho to answer this question.
Why do I answer all the questions?
Because you are the key person for today.
Increases potency of metastatic niche. Drugs to accumulate in tumor cells. I think this is probably a bit difficult to prove actually, because tumor microenvironment is one of those things that people have spent a lot of time trying to understand more. So would it increase the potency of metastatic niche? I wouldn't expect it to do so, because as we see before, the immune response will be enhanced. Saying that the suppressor T cells seems to also be enhanced at the same time. So we don't know which force is more powerful in the microenvironment. I think in terms of drug perfusion, that one is certainly a positive effect. In terms of the immune response and whether it affects I don't think it affects the potency of the metastatic niche. There's no reason why it should, unless you say it becomes a more immune suppressive environment, which is still unknown. So that means that's an active area of research. What's the effect on the tumor microenvironment? Yeah. But the clinical studies are positive.
I think, sorry, Prof, I missed it. I think there's Dr. Sham Srivastawa would like to answer this question live also. Shall we invite Dr. Sham like to answer this question also?
Sorry, Dr. Xiao is still doing his clinical time, but I recorded the question for him. And if he has answers, where can he send his answers to? Maybe address it to you, and then so you can help to disseminate the information to everybody or to that
Sure.
particular.
Maybe you can just tap in the chat box. Then I can answer. I mean, I can read up the answer.
Okay. I'll do just that.
Okay, while waiting for Dr. Xiao to answer the question. Next, the question from Pawini Mahashitiwat. Do you use hyperthermia with SRT or immunotherapy? I think this round, let's get the Dr. Nasha HUILGOL to answer this question. Dr. Nagraj?
What exactly is the question? Do we use chemotherapy?
Do you use hyperthermia with SRT or immunotherapy?
Oh, okay. Oh, all right. Okay. See, that's a good idea. Not much explored. Traditionally, what has happened in most of the clinical trials or in the personal clinical practice, immunotherapy is immune response, exploiting the immune response is something very recent. But most of our experience has been in a very conventionally fractionated radiotherapy. But yes, it is a very interesting proposition and a possibility. It needs further exploration. There are no trials, but yes, the people are now talking about it.
Okay, thank you, Dr. Nash. How about from Thailand, Dr. Sunanta? Do you use hyperthermia with SRT or immunotherapy? Do you have any experience on that?
In my department, I have not experienced the hyperthermia combined stereotactic radiation or immunotherapy. Yes. But,
how about Prof Ho? Would you consider in the future, or do you have already have something in your mind?
I think it's
I haven't designed the study yet. I don't know whether I'm allowed to use it outside the study. It's hypothetically interesting. Yeah. There's so much time that we cannot do a lot of studies that we want to do.
Okay, I think Sunanta, sorry, just now, do you like to say something, Dr. Sunanta? I can't hear you. Can't hear you. Please
I think
unmute
so,
yourself.
with the Dr. Ho, I think the hyperthermia is can increase the immunity in the body. So this is the interest. I think that immunotherapy plus the hyperthermia in the future is the interesting to explore in the future.
Yeah, I agree.
Okay, next I think we have a question for Brandon Hsia. Between hyperthermia and modulated electrohyperthermia, is it one potentially more superior than the other? Prof, what do you think? Is that, in your opinion, which one is superior?
I don't know what is modulated electrohyperthermia. Would that be the electrophoresis? Electrophoresis is not available in Malaysia. I know if they do it in Hong Kong, so you put 2 electrodes and basically you just heat up that area. And the first one, hyperthermia, I don't know what it means actually. So it's a regional hyperthermia. So actually in the end, it's going to be the whatever temperature you, for hyperthermia concept, whatever temperature we reach, for how long is the duration. So to achieve the tumor, the enhancement ratio, hyperthermia enhancement ratio. So so is one more superior than the other? I don't really expect it to actually. I think it's just the different variation of the theme. Depends on whether you can focus your heat at the tumor. Actually, for a best hyperthermia is you get the heat concentrated at the tumor and nothing at the fat or somewhere else. If you like doing radiotherapy, then you achieve the best result.
Okay, I think Brandon Chen, would you like to present yourself and explain your question in more detail so that we can understand more, and I think our panelists and speaker can, I mean, I can give you a better answer, like Brandon Chia. You like to ask in live? Maybe we shall get Dr. Naksha Hugo. What do you think between hyperthermia and modulated electrode hyperthermia, is which one is more superior, or is it the same? Dr. Naksha? Dr. Naksha Hugo, you hear us? You hear me?
Yeah, so what is the question? Sorry.
Yeah, between hyperthermia and modulated electrode hyperthermia, is one potentially more superior than the other? Between hyperthermia and modulated electrohyperthermia.
Yeah, see what I presume that when he says electromodulation, whatever that he says, I would presume that he is talking about multi-phased array systems wherein you can steer the inputs in a 3D. I mean, he has already spoken about it. So yes, if one can do a treatment planning system before, on based on perfusion and dielectric constants and so on and so forth. Having said that, there are just a few machines wherein you can steer the inputs based on earlier treatment planning system, or if you have an it is integrated with the MRI for thermometry, then you can do that. So otherwise, just on a plain radio frequency like a thermatron, which RF based one, you can modulate the input definitely, but not the way it is conceived in a 3D phased array systems.
Okay, thank you. How about Dr. Sunanta? What do you think? Between hyperthermia and modulated electrohyperthermia, in your opinion, which one is more superior? Is that the same? Dr. Sunanta?
But in my experience, I'm not use the moderated electrohyperthermia. I'm not sure about for to compare the moderated electrohyperthermia and the hyperthermia. Yes.
I think it is
Okay.
asking about the capacitive and the radiative system. So as we discussed before, as Dr. Nagraj just described, the radiative system, you can focus the energy more by the constructive interference or destructive interference. Therefore, you can heat up a certain place faster and a bit more focused. But the cost is different. It's a bit more expensive, the radiative system.
Okay. Is there any other question from the floor? Anyone else? I think there's a message from Dr. Xiao because he's still doing his clinic. So I think he would like to answer the question, and once he's done, and email it to us, and then we can send it to the person who raised the question. So I think Rian Apretoni, maybe you may leave your email address so that later on we can email to you. So I guess there's no more question from the floor. Is there some Hi, I think this is Junichi Fukada. We can't hear you. Do you like to speak again? You would like to unmute yourself and ask your question to us so that I think panelists can answer your question. Right. Okay, I think there's something from Brendan Chia. According to him, in addition of the electrophoresis, something like oncothermia, right? And there's some comment from Wei Cheng Wong. Saunas have temperature up to 70 degrees. Patients on hyperthermia sometimes cannot tolerate lower temperature as given in hyperthermia. Are there physiological reasoning behind this?
Hello, can I just make some comments, please? Yeah, I mean, I heard somebody talking about 70 degrees Celsius. 70 degrees Celsius, firstly, it's very that's an ablative temperature. That is only when you're talking of HIFO or RF-based ablations. Okay, that 70 and above. So that's a different kind of heating than the kind of heating that we are talking about, which should not exceed more than 45 degrees Celsius. Having said that, it's very, very difficult to achieve that temperature. Now, when we were talking of oncothermia, Professor Saz talks about cellular heating, which depends on the resistance, differential resistance or higher resistance of cell membrane, and he does not, or they do not emphasize too much on the intratumoral temperature. So that's a different ballgame, but there are no head-to-head comparisons. And even I think there is a vast experience, but then there are very limited randomized trials using oncothermia.
Okay. Okay, thank you, Dr. Nagraj. I think there's a message from John Joseph to Professor. We get hyperthermia treatment from Dr. Ho Clinic.
We still have the two machines up there for compassionate use at the moment. We haven't got the money to pay for it, to buy it outright yet. So we'll see how long we can keep it. It costs about 3 million per unit, so it costs a lot of money.
Okay. I guess there's no further question and comments from the floor. If no further questions, I would like to thank you to our speaker and all panelists for their excellent talk on this topic, and all the participants. Without your input, ideas and discussions, this webinar would not have been the success it has. So we hope to see you soon on the next FARO webinar.
Bye, and thank you so much for inviting me. Bye.
Thank you. Bye-bye.
Thank
Bye.
you. Thank you.
Bye. Thank you.
Thank
Thank
you.
you.
Thank
Thank you,
you.
Prof. Sat.
Thank you.